Arthroscopic Management of Partial Cuff Tears by Ben Shaffer, MD. This is an example of a clinical case dilemma. We've got a partial undersurface cuff tear. How much of this should we debride or surgically clean up? What percentage thickness tear does this constitute? And should it be repaired? If so, how? Cadaver and clinical studies have shown that in fact, partial cuff tears are more common than full-thickness cuff tears. And this is an age-dependent phenomenon with a peak incidence in cuff pathology in the 5th and 6th decades. Most of them involve The purpose of this talk is to provide an overview of partial cuff tears, explain the etiology and natural history of this problem, and then discuss evaluation, treatment options, and surgical repair of partial cuff tears. There are three types: articular-sided, confined entirely within the tendon substance, and those that are confined to the bursal surface. As an example, shown here is an articular-sided tear, particularly seen in younger population. Intratendinous pathology can affect the younger population and middle-aged patients with degenerative changes, and bursal-sided cuff tears, which commonly occur in impingement. Articular-sided tears are 2 to 3 times more common than bursal-sided. This is common in overhead-throwing athletes. The failure is through tensile overload and internal impingement. There are two types of articular surface tears: pasta lesions and paint lesions. Let's look at these. PASTA stands for partial articular-sided supraspinatus tendon avulsions, found by Snyder in 1994. The etiology of articular-sided tears is multifactorial. It fails by tensile overload and internal impingement. There's some changes in the pathophysiology, including the arterial supply, elasticity, and forces. It basically exceeds the ultimate stress-strain curve, and contact with internal impingement is a known condition. Paint lesion tears was coined by Conway. These are partial thickness articular-sided intratendinous tears, shown here by palpation between the articular layer, seen directly in front of us, and the bursal layer, not seen. These are consequent to the phenomena of internal impingement described by Gilles Walsh and others. In this mechanism, there is extension of the tear from shearing forces and internal impingement into the infraspinatus. Intratendinous tears, on the other hand, have a variable incidence and may not be related to symptoms at all. Intratendinous tearing does suggest the presence of shear within the tendon. Evaluation begins with a careful history. We want to know the mechanism of injury. Is it related to prolonged overhead activities, or was there an acute traumatic event? And what are the symptoms? They may be minimal, or they may present like a full-thickness cuff tear. Often, overhead throwers complain of fatigue and or pain with their activities. The clinical course is variable. It may be nominal, or may be consistent with full-thickness cuff tear, with pain during daily activities and at night. Often the symptoms will overlap with subacromial pathology, biceps tendon involvement, and labral tear. Physical examination shows that impingement signs of Neer and Hawkins are common. Look for decreased internal rotation due to posterior capsular tightness, especially in the throwing population. And look for scapular dyskinesis, viewing them from behind. Imaging begins with radiographs, which are necessary to rule out other pathology and specifically to look at the shape of the acromion. MRI is not always easy to distinguish tears from tendinopathy. Ultrasound is very effective, but unfortunately operator dependent. Gadolinium-enhanced MRI with contrast injected in the joint best demonstrates the lesion, as shown here in this picture with the red arrow pointing directly into the intratendinous lesion. These views are best obtained in an abducted, externally rotated, or Aber sequence position, mimicking throwing. Studies have shown that the typical coronal oblique view is only 21% sensitive in detecting pathology of the cuff in undersurface or intratendinous tears, whereas the Aber sequence views allow us to detect it virtually all of the time. This is an example of the Aber view. We're looking directly at the infraspinatus tendon, which we see here has fluid within it. As an example to contrast, look at this top right inset picture, which shows a beautiful full thickness cuff footprint. MRI changes are particularly common. In this one study by Andrews at spring training, they looked at 31 asymptomatic professional pitchers. They found that 87% of them showed abnormal rotator cuff appearance. 39% of them showed humeral head changes, so we know that these changes are common in throwers. In this study by Miniaci, they evaluated MRI findings in both shoulders of 14 symptom-free professional pitchers. They found that 79% demonstrated low signal intensity changes in the throwing shoulder, consistent with tendon pathology and/or partial thickness cuff tears. 86% had mild changes in their non-throwing shoulder. Again, a caveat to take with a grain of salt the significant MRI findings of the cuff. What's our treatment for partial cuff tears? Well, in the absence of trauma, non-operative treatment is the appropriate starting point for most patients, including throwers. It must be individual. Rehabilitation follows a structured, multi-phase program. This includes controlling inflammation, restoring muscle balance, improving soft tissue flexibility, enhancing proprioception and neuromuscular control, and finally returning the athlete to competitive activities, including throwing. During rehabilitation, we have to carefully monitor the thrower's mechanics and intensity during interval throwing program. Why is this relevant? Because Wilk and Andrews measured the throwing intensity of healthy pitchers, and when they were asked to throw at 50% of the effort, the actual effort that was made was about 83% of their maximum speed, based on use of a radar gun. When they were asked to throw at 75% of their effort, pitchers threw at 90% of the maximum effort. What that tells us is that there is difficulty in controlling velocity at lower throwing intensities amongst athletes who are returning to the previous. So what's the good news in rehabilitation? Well, it seems that non-operative treatment is effective for most patients, but we don't know the objective success rate. That's because of variability in the cohorts that we analyze and the design of the studies. So what are our treatment principles? Well, to know that, we have to understand the natural history. Codman in 1934 accurately predicted that these lesions never heal. This has been corroborated by a number of subsequent. Yamanaka looked at these lesions by MRI and found that overall there was progression of partial cuff tears 80% of the time. The prognosis for healing is poor because there's separation of torn margins, poor vascularity, a synovial layer that prevents healing, and continued pathologic stresses on the. The indications for operative intervention are those patients whose symptoms are unresponsive to non-operative treatment. To some degree, it's variable depending upon the patient, their demands and goals, and the timing with respect to the season. And the threshold is different in throwers. Overhead throwing athletes commonly have MR changes, and there's a disparity between their findings and pain. Surgical alternatives include debridement, which is sometimes necessary to determine the true extent of the tear, or debridement followed by repair. Our guidelines in general are the 50-50 rule. If it's less than 50% torn, we generally will debride with or without a decompression of the subacromial space, and when the tear extent exceeds 50%, we think about an arthroscopic or mini-open repair. How do we measure the depth of the tear? Well, we can base it on the exposed normal footprint. We can use an instrument of known dimensions to determine the relative depth. We can then compare it to the known cuff insertion dimensions, which averages 12 millimeters. And Jed Kuhn has looked at this and shown that inter-observer variability is high, with only 49% agreement amongst clinicians. A marking stitch is sometimes helpful at delineating the extent of the tear. Here we've passed through a spinal needle into the tear. We can see it on the articular or glenohumeral side. And when we see on the bursal side, look at how this blunt switching stick falls right into the defect. Remember when we look at the tendon detachment that the supraspinatus is attached right at the articular margin, whereas the infraspinatus is about 3 millimeters off the margin. Let's look at some surgical techniques. First, we want to do a glenohumeral arthroscopy. We have to treat associated pathology. Here's an example of an athlete who's got an inferior and posterior labral tear that extends up into the superior labrum, along with undersurface cuff pathology. This is an example of a case debridement, a 19-year-old pitcher with pain related to throwing. And this is a good type of problem because it involves a very small partial thickness tear that's debrided, and he's going to be able to return. What are the results of debridement alone? Well, there's no evidence of healing even if it takes away the patient's symptoms. Weber has noted that on second look arthroscopy, healing was never observed. The results from debridement and acromioplasty without repair were only fair. There's a number of articles that have examined the outcome after debridement. Andrews has noted that 85% recovery is found in most throwers, but Warren found that only 45% of throwers were able to return. So there's a considerable disparity which depends upon the population you're alluding to. Recently, there's been an emphasis on repairing partial thickness cuff tears. This is based on concerns about failures clinically with debridement alone, the known risk of progression, and the evolution of new techniques which may facilitate our success. The alternatives for repair include converting it to a full thickness tear and then repairing it as we conventionally do, performing a transtendinous repair, which will be demonstrated here. In a transtendinous approach, described here by Ide, an arthroscopic suture anchor has been placed, and the limbs of the sutures are consecutively passed using a spinal needle technique through the footprint on the articular side of the tear. As this is performed, the sutures can then be tied and approximate the articular side of the tear up against its normal footprint. The bursal side of footprint has been preserved, and this results in a more anatomic configuration repair. This is an example of a softball player who has right shoulder pain for a year and has an articular sided tear that is about 70% thickness of the full tear. Here we've abraded the tuberosity where the cuff attaches, and we're grasping the tendon and pulling it over directly into the area that it needs to be attached to, the greater tuberosity. We're going to do 2 rows to reattach this tendon. First we'll go laterally and we'll insert an anchor. We have to tap this bone in younger athletes who have very dense bone. We've passed an anchor that has sutures attached to it. We're going to retrieve these sutures through a cannula out the front of the shoulder. We're then going to use a spinal needle, passing it through the cuff and inserting either monofilament or in this case a suture shuttle. We grasp one limb and retrieve it using the suture shuttle. We'll then grasp the other limbs of the suture and pass this. Next, we're going to establish a medial row. This medial row anchor has sutures attached to it, and these again will be passed more medially through the torn edge of the cuff tendon. The needle can even be used to reduce the tendon's edge in the appropriate position. We're going to pass one more suture here, having placed an anchor at the posterior margin of the tuberosity. Now we will go up into the space above the glenohumeral joint in the subacromial space and grasp each of these suture pairs. And as we tie these knots carefully down, we see a full thickness repair achieved through a transtendon technique. And here we see the tendon opposed to the footprint beautifully. This is an example of an intratendinous repair in a 19-year-old baseball pitcher. Notice this cannula in the front. This is footage afforded by John Conway. We pass a probe and confirm the depth of the lesion, which is now debrided on the articular margin with a shaver. Now we're going to use a percutaneous technique with spinal needles. In this schematic, we see the sutures have been passed. When they are then tied on the bursal side, it approximates the two layers of the tendon. Postoperative repair rehab program is variable depending on how the procedure was done and the degree of security, but involves ultrasling for 4 weeks, active and assistive range of motion of the hand, wrist, and elbow, active motion of the shoulder starting at week 6, with light resistance at week 12, and throwing beginning as early as 6 months. The results of arthroscopic repair of partial thickness cuff tears are limited. In one study with 68 patients, 5-year follow-up showed that this was equivalent or better compared to mini-open repairs. A group of 16 out of 17 patients in IDE series had a good or excellent result. 86% of patients had good and excellent results in Weibel series. And finally, Wolf looked at 15 patients that had a transtendinous repair technique. At over 2 years, 100% good and results. But the repair outcome in throwers may be different than the conventional population. Conway, for example, has shown that in a transtendinous technique he had a return to throwing of 89%, but there was also concomitant pathology addressed, so this wasn't isolated transtendinous partial cuff tear repairs. Beware of the thrower with full thickness tears. This study out of Andrews has shown that in a group of 16 professional baseball players, 12 of whom were pitchers, that underwent a full thickness cuff repair using an open technique, only one of the 12 pitchers was able to return to a high level of competitive professional baseball. It is very difficult to return as a pitcher at a high level of competition following repair of a full thickness cuff tear of the dominant shoulder using a technique at least. Now, what's our algorithm with a partial cuff tear for a non-thrower? Well, we start with non-operative treatment. If they're improved, we're done. If they're unimproved, we proceed often with arthroscopy. If the cuff tear is less than 50% thickness, then often we'll perform a debridement alone. If the tear exceeds 50% thickness, then we may go ahead with a repair. Of course, we treat any associated conditions. In a thrower, our threshold for repair is different. If they have less than 75% involvement of the tear, we're going to debride them alone. If the tear exceeds 75% of the thickness, then we're going to probably be forced to repair the cuff. And this may change depending on the athlete's age, degree of impairment, and goals. Of course, we also treat associated conditions. Throwers are different. We try not to fix partial cuff tears if possible because of the results. Bursal-sided tears are different. They may be associated with subacromial impingement. It may be a primary problem or it may be secondary. This is an example of the technique that we use in a bursal-sided tear. Here, the undersurface of the cuff is pristine. When we place the scope in the bursal side, however, this subacromial space allows us to view a partial thickness triangular shaped tear. We're going to preserve the articular-sided margin, and we're going to establish 2 holes here with the use of this punch in which we're going to insert suture anchors. The anchors with their associated sutures have been attached. We're now looking from a different perspective and pulling the bursal side over, and we're going to pass through sutures through the bursal side of the tear. This is an example of one of the devices used to pass the suture. And once we've done this, we're going to start tying the pairs of sutures on the bursal side, and by doing so we can see how we effectively pull the bursal side over and reattach the tendon in a way that restores normal tendon integrity for a partial thickness tear on the bursal side. Sometimes there's fraying of the CA ligament or stenosis of this compartment. In this case, the patient did have impingement, and we used a cautery to identify and a burr to debride the undersurface of the acromion. In summary, treatment of partial cuff tears must be individualized. Non-operative treatment is often effective. Arthroscopy is appropriate for those patients who have persistent symptoms. The indications for repair of a partial thickness tear remain elusive. The 50-50 rule currently is empiric, and we have to consider a higher threshold for repair in throwers. The outcomes for repair of full-thickness cuff tears with the current techniques is not as good in overhead throwing athletes, in particular pitchers. The outcomes with newer techniques remains unproven. Less is probably more. Thank you for your attention.